Hello, a very good evening to you all. My topic is amblyopia in STRAATSMA syndrome. This is the picture of Dr. Bradley R. STRAATSMA, who first described STRAATSMA syndrome in 1979. He reported 4 cases of STRAATSMA syndrome. It is a very rare syndrome with a triad feature of myelinated retinal nerve fibers, high myopia, and amblyopia. Myelinated retinal fibers, or papillae leporina, was first described by a German pathologist, Dr. Virchow, in 1856. Morphologically, they appear as white or grey-white striated patches with frayed borders around the optic nerve head. This is a fundus photo of one of the patients in our case series who presented with myelinated retinal nerve fibers with frayed borders around the optic nerve head. This is another fundus photo of left eye of another patient of our case series with extensive MRNF. Amblyopia in STRAATSMA syndrome consists of 2 components. One is due to organic defect in retina, which is not treatable, but the other is functional due to anisometropia, which does respond to treatment and should be corrected. Strabismus is a frequent finding in STRAATSMA syndrome, and high myopia is mainly axial myopia in STRAATSMA syndrome. The purpose of our study is to describe the density of amblyopia in STRAATSMA syndrome and to assess the visual outcome in terms of best corrected visual acuity. Coming to methodology, our study design is a retrospective case series, and we have examined 20 patients who presented with myelinated retinal nerve fiber, myopia, and amblyopia at the Pediatric Ophthalmology Department at Shankara Nethralaya Medical Research Foundation, Chennai, in the period from January 2006 to May 2019. This is a raw table that summarizes the parameters which we have taken into consideration. We have incorporated age, gender, eye affected, spherical equivalence of the affected eye, type of strabismus, pre-treatment visual acuity in Logmar, type of treatment given, post-treatment visual acuity in Logmar. Coming to results, the age at presentation in our case series ranged from 9 months to 54 years, with mean age being 17.9 years. The males predominated our study, with male to female ratio being 1.85:1. There was no statistical difference between males and females in the study by STRAATSMA et al., although older studies have reported male predominance. And strabismus was documented in 9 out of 20 patients in our series, which accounts to 45%, and case series by Tarabishi et al. Also have documented 45% affection. Out of the 9 strabismus patients, 6 presented with exotropia and 3 had esotropia. Karimi et al. Has also established the dominance of exotropia in their study. Best corrected visual acuity pre-treatment ranged from 2 to 0.3 in 18 patients, and 2 were unrecordable. The refractive error ranged from -1 sphere with -1.25 cylinder at 180 to -18 sphere with -4 cylinder at 120. All patients were myopic, supporting the previous studies on myelinated retinal nerve fiber being more common in myopic than in hypermetropic eyes. In our study, 11 out of 20 patients, that is 55 patients, came for follow-up, and 8 among them, that accounts to 72%, underwent amblyopia treatment by part-time occlusion and penalization, and 4 among them, that accounts to 50%, showed good response. And the mean pre-treatment visual acuity in Logmar was 1.12, and post-treatment visual acuity in Logmar was 0.78, which was actually very good favorable prognosis. And the range of pre-treatment visual acuity in Logmar was 2 to 0.3, with post-treatment visual acuity in Logmar 1.77 to 0.2. So in conclusion, despite having poor prognosis in general for STRAATSMA syndrome, 50% patients who reported for follow-up in our case series following amblyopia treatment by ocular patching and penalization improved by an average of 2 lines. This necessitates our recommendation to aggressively pursue occlusion therapy in these patients and to compel the parents to do so. These are my references. Thank you, everyone.